Thank you very much, Elliot, and thank you for the organizers of this meeting. I feel really privileged to be here, and I'm excited about the discussions that we're going to have today and tomorrow. This sort of feels a bit like the culmination of a 35-year career with an interest in thrombosis in trauma, so I feel really privileged to be here today. I have my slides, please. So I have the task of sort of setting the stage for the discussions that follow today. I'm going to talk about where we've come from with respect to VTE and trauma and where we are now. The future will be discussed tomorrow. Over the years, I've had industry support for a lot of the research projects I've done or other involvement. I have none currently that are relevant. So I just want to start by saying how much I admire the work that you all do in this area, the skills that you bring, the commitment, the leadership, the creativity that you've brought to this field. I've been a student of VTE and trauma for 35 years, and I really admire you in this room and others in your commitment and your hard work in this area. So I'm going to basically do a very quick historical perspective of where we've come from with respect to VTE and trauma, and then I will talk about our current approach to preventing this complication as a means for thinking and having this further discussions about it. Looking back historically, before 1987, I choose 1987 because 1986 is when I started to work at Sunnybrook Hospital, Canada's largest trauma center. And I had an interest. I just finished training in thrombosis, and I'm now coming to a trauma center. And I thought, let's have a look at this problem. And it was really easy to absorb the literature at that point in time because there wasn't that much. And so the other day, I put together the files that I have, and I'm not obsessive about including every paper that's ever been written, but I just took out of my filing cabinets the files related to VTE and trauma. And so it's a major challenge to try and select from among this big body of information what's really important. I also want to add two caveats, and that is, I believe that there's more than one way that we can prevent VTE and trauma. There's no one only this way to go model that we can use. And the second caveat is that none of you will agree with everything I'm going to say, and that's okay, and that's why we're here. So 1986, again, I started working at Sunnybrook, and I had an interest in thrombo, and this is going automatically. Is that what you want? Can we go back a couple? Is there any way I can change the slides? Okay, perfect. Okay. Next. So we're going to go from 1986 to about 10, 20 years ago, and then to 2022. So in 1986, trauma patients did not receive thromboprophylaxis in my hospital or most other places. It just wasn't a priority for these patients. Patients weren't screened for DVT, prophylactic filters hadn't been invented yet, and there wasn't a single guideline for thromboprophylaxis, not only in trauma, but for other patient groups as well. One of the major concepts that I have of VTE and trauma comes from this slide. I tried to depict how we were thinking at that time, and that is that trauma patients obviously come to a hospital trying to bleed to death, many of them. And that concept of when does the bleeding risk decrease, in the old days, the concept amongst my colleagues who were the trauma surgeons was that the bleeding risk persisted for some longer period of time. And therefore, it was heresy to consider using an anticoagulant in those patients because the bleeding risk was perceived to be high, it was high, and perceived to persist for a longer time. And the idea of thrombosis risk everyone was aware of it, but there was a lot of uncertainty about how common it was and when it occurred. I won't go through this in detail, but even in the 1880s, there were papers written about PE and fatal PE in trauma patients. In the 1940s, a Swedish surgeon and a surgeon from Toronto speculated that it might be interesting to give anticoagulants to trauma patients to see if we could prevent thrombosis. So that's in the 1940s, and it has taken about 50 years or more before that has been realized. The landmark paper published in 1961 was written by two pathologists at the Birmingham Accident Hospital. And they looked at 900 autopsies amongst trauma patients who died there. And in their unselected autopsies, 80% of those patients were found to have DVT. Of greater concern is that 1% of all of their trauma admissions, or more than 1%, died of autopsy-proven PE. So they really raised the idea that this was a significant problem in these patients. A group from Cook County Hospital looked at a series of trauma patients, and they did contrast venography in those patients, none of whom received prophylaxis because that wasn't standard of care at that time. And they found that a third of those patients had DVT on venography. And again, this raised concerns. The authors, however, also said in their paper, routine prophylaxis may produce more trouble than it prevents. And that concept pervaded the trauma world for quite a while. The very first guidelines on VTE prophylaxis at all was published in 1986, happened to be the same year that I started to work. And so the very first guidelines were in 1986. Can we go back, please, one? Back. One more. Okay. And with respect to trauma, they stated the risks of thromboembolic disease and subsequent PE have not been specifically defined for the general population, trauma population, and the efficacy and safety of various forms of prophylaxis have not been evaluated in those patients. In 1990, a group from San Diego looked at a large number of trauma patients, many of whom got some prophylaxis, and they looked at risk factors for VTE that were understood at the time. And among the patients who had at least one, what they defined as a major risk factor for VTE, 7% of those patients had DVT, while in the larger number of patients who didn't have any of these risk factors, none of them had clinically relevant DVT. Now, the patients who didn't have risk factors weren't screened, whereas the other patients were screened for DVT. So there are limits to this. But again, raising awareness of VTE as being a problem in these patients. Well, we thought that the paucity of data in this area warranted doing a high-level study, and so we looked at almost 350 consecutive trauma admissions at our center, none of whom got prophylaxis. We didn't withhold prophylaxis, but prophylaxis was not being used in our trauma unit at that time at all. Hard to believe in 2022 that could be the case, but that was the standard of care. And these patients had bilateral contrast venography as at that time, the gold standard diagnostic test for DVT. Next. This is one of the most important slides that I can show today, and this is the reason why this kind of research hasn't been done more often. This is Karen Code, my research nurse, is smiling because in this ventilated bilateral chest tube central line patient whose legs are very edematous, she's found a vein to do contrast venography. We took venography out of the radiologist's hands because the study would not have succeeded had we allowed the radiologist to be involved. So she did all the venograms in this study and the randomized trial that we did. Next. And so our DVT rate in these 349 patients was 58% and 18% of proximal DVT. Keep in mind that these are asymptomatic DVTs, and not all of these DVTs would raise our heart rate, but The reason why this was important is because there was similar venography data for a number of other patient groups at that time, and therefore we could compare what was going on in trauma with major orthopedic surgery or in general surgery. And so our philosophical question was, are trauma patients more like general surgery patients, or are they more like orthopedic patients? And given the DVT rates in the study, these are more like arthroplasty patients, for example, or hip fracture patients, where half of them had asymptomatic DVT. In this study, unfortunately, there were 3 fatal autopsy-proven PEs, and it became difficult to continue to do the study when you're seeing fatal PE. Our assumption was that finding DVTs in the other patients and treating those hopefully prevented other people from dying of PE. That was our justification. Now, we had enough patients that we were able to look at subgroups of patients, and I won't go through this in great detail, but there were 2 surprises that we came up with. Number one, that patients with non-major trauma, i.e., from the VTE perspective, patients with face, chest, or abdominal injuries, half of those patients had asymptomatic DVT. The second observation was that a quarter of the patients with orthopedic trauma had proximal DVT. So this really raised our concerns that we were dealing with a bigger problem than we had appreciated before. We were able to look at risk factors for thrombosis, and to this day, this is the only published study that has actually developed a risk assessment model for VTE. All the other risk assessment models are done in patients who receive prophylaxis. So it's asking a different question. It's asking a question, patients who get prophylaxis, how many of them have VTE? This is the only study where these patients did not get prophylaxis. And we can say, what were the independent predictors for thrombosis? Age. If you were transfused or had surgery, you were twice as likely to have thrombosis. More importantly, if you had a major orthopedic injury, you were 5 times more likely to have DVT. And if you had a spinal cord injury, the risks were really quite high. And if we look at a large body of information, there are 50 to 100 studies that have looked at risk factors and trauma. The major risk factors are on this slide. Age, lower extremity pelvic fracture, spinal cord injury, delay in thromboprophylaxis has unequivocally been shown to be associated with thrombosis. And then a bunch of other risk factors, major head injury, venous injury, femoral line injury, severity surgery, and reduced mobility. So now I'm going to switch a bit to prophylaxis. So knowing that these patients are among the highest risk group for thrombosis, what can we do to try and prevent the complication? Well, first of all, just a couple of words on SCDs. We don't have a single SCD in my hospital that's used in trauma patients, I'm sorry to say. And it's not that we're philosophically opposed to it, because we are aware that they don't cause bleeding and they might reduce VTE, but we're also aware that the evidence supporting SCDs is not very strong. The evidence is pretty limited. They have to be used bilaterally if they're going to be used at all, and continuously. Compliance has been poor. And importantly for us, having SCDs on may lull practitioners into thinking that they're on prophylaxis and may delay something that's more effective. However, I think it's reasonable to use mechanical prophylaxis in patients with early contraindication to low molecular heparin. That's pretty logical. It might be useful in patients having major surgery where you want to avoid anticoagulants, and it might be an additional modality of prevention to low molecular weight heparin, although I'm not certain about that, frankly. Our exclusive use of low molecular weight heparin, we have not used unfractionated heparin for more than 20 years in our hospital for lots of pharmacokinetic reasons, and because there's a lot more evidence for low molecular weight heparin than for unfractionated heparin, both in trauma and other patients. And the next slide, I'll show you our, whoops, can we go back? One more. And it's now unequivocal that there's no greater bleeding with low molecular heparin than unfractionated heparin. The reason why we haven't used heparin is because we are, in fact, a heparin-free hospital. We are a avoid heparin hospital across the board, and that's because we want to prevent heparin-induced thrombocytopenia. And the argument in favor of using fractionated heparin in the past has been based on cost. And for us, the cost is not greater, and this is just costs from this month. These are the formal acquisition costs of low-dose heparin and low-molecular weight heparin. In actual fact, our low-molecular weight heparin costs are about 1/10 of this because of all the kickbacks from the pharmaceutical company, which doesn't apply to heparin. So we made the change from unfractionated heparin to low-molecular heparin based on heparin-induced thrombocytopenia, but we were not penalized using a drug with greater cost because for us the cost was not greater. Next. Going now to 1994, where Dr. Knudsen did a large study of patients who were randomized within one of three groups to various types of prophylaxis, basically low-dose heparin or mechanical prophylaxis or nothing. The patients were ultrasounded every 5 to 7 days. Overall, proximal DVT was seen in 7% of patients without prophylaxis. SCDs appeared to be highly effective in neurotrauma patients where there were no DVTs in those who got SCDs, and there were 13% of the neurotrauma patients had DVT. In the non-neurotrauma patients, SCDs had an event rate which was comparable to those without prophylaxis, and low-dose heparin appeared to be more effective. So we also did a randomized trial comparing heparin and enoxaparin. We used a standard dose of enoxaparin, and we used a conventional general surgery, orthopedics, and trauma dose of heparin. Can we go back, please, one? And in this trial, randomized double-blinded trial, and we used venography again as the outcome measure. Next. So this study showed that all DVTs were reduced with low-molecular weight heparin by 30%, and more importantly, proximal DVT, the outcome measure that we're more concerned about, was reduced 58%. With the use of low-molecular weight heparin. There was no difference in major bleeding in this study between the two groups. Now moving to 2002, and all of you are aware of the huge impact that these EAST guidelines have had on practice in the trauma world. And I'm just going to highlight a couple of the statements from this guideline. Low-dose heparin was said to have very little proven efficacy and cannot be supported. That was a level 1 recommendation. Pneumatic compression devices were shown to have no benefit of the use over no prophylaxis and can't be supported. Low-molecular weight heparin should be strongly considered for use in all high-risk trauma patients when their bleeding risk is acceptable, reasonable, and then some statements on prophylactic IVC filters and ultrasound. And then a more recent study with James Byrne, who's here with us. Thank you, James. Looking at the Trauma Quality Improvement Database from 2012-2015, comparing low-molecular weight heparin and low-dose heparin in propensity-matched groups, showing an almost 50% reduction in PE in this 38,000 patient per group study with low-molecular weight heparin over low-dose heparin. Now we're sort of 10 to 20 years ago, where low-dose heparin is now used routinely in trauma patients at a fixed dose. However, thromboprophylaxis use in the past was highly variable amongst trauma units. People were starting to screen patients for asymptomatic DVT. There was selected IVC filter use in some trauma units. And there were now two sets of international guidelines, or the EAST guidelines and the American College of Physicians guidelines, that talked about trauma patients. So first, I'm going to talk now about a few of the issues that relate to prophylaxis and trauma. So the first issue is how early should we start prophylaxis? And so on the bottom there on the left is Alison Bond, who's a thrombopharmacist in our unit, and she dreams about going to the site of the injury and starting the patient on Lovenox as an issue of how early can we start. She has a recurrent dream about that. So if we look at just on one slide of timing of prophylaxis, when should we start low-molecular weight heparin? There's no question that delaying the start of low-molecular weight heparin leads to more VTEs. And if we start low-molecular weight heparin early, it's associated with fewer VTEs. And it also turns out that early start of low-molecular weight heparin is not associated with more bleeding. And that's been shown in TBI patients, in solid organ injury, pelvic and spine fractures and in spinal cord injuries. The second issue is, should everybody get the same dose of low molecular weight heparin, or should we adjust the dose based on some variable? It turns out that, thank you. It turns out that 30 to 80% of trauma patients given a standard dose of Enox, 30 BID or 40 once a day, do not achieve a target anti-10A level that would be considered to be a prophylactic level. However, low levels of anti-10A have not consistently been correlated with increased risk of VT. There are some studies that suggest yes, but many suggesting not. And there's no study that's shown that high anti-10A levels are associated with increased risk of bleeding. I think adjusting Enox with anti-10A level makes a simple decision much more complex and costly. And it turns out that if one uses weight-based dosing of Enox, adding anti-10A levels adds nothing significant to that decision, just makes it more complicated. With respect to prophylactic IVC filters, for those of you in the room, many of you have more knowledge and experience about this than I. In my center, there has never been a single prophylactic IVC filter put in a trauma patient over the history of our trauma unit, not one. So there are very wide variations in the published literature on the use of prophylaxis, of prophylactic IVC filters, which cannot be explained by the severity of the patient's injuries. It's based on local practice rather than patient risk. The early studies of prophylactic IVC filter use tended to use suboptimal prophylaxis as determined by the standards that we would consider appropriate these days. The randomized trial by Ho, which I'll show you on the next slide, showed no reduction. Go back, please. No reduction in PE plus mortality. Filter use increases risk of DVT. And if you do calculations based on known rates of PE and complications, the complication rates of IVC filters greatly exceed the complication filters are designed to prevent. Many filters, as you know, are not removed with huge costs, and fortunately, there's been a progressive decline in filter use throughout North America. Next. And next. So Kwok Ho did a randomized trial in Perth, Australia, looking at patients who had a contraindication to anticoagulant prophylaxis that exceeded 72 hours after admission. And they were randomized IVC filters placed within that time period or not, and there was no difference in the event rates of symptomatic PE and death. What about Doppler ultrasound screening for asymptomatic DVT? Again, there's huge variations in practice amongst trauma units. There is no question that screening Dopplers detect more DVTs, but the clinical significance of those detected DVTs is quite uncertain. And many of the studies show no reduction with screening for symptomatic VTE or for PE with the use of screening. And keep in mind that the patients in whom screening has detected a DVT, those patients need treatment, and that treatment can cause harm and substantially greater costs associated with screening. And one of your colleagues, David Spain, said in relation to screening, if you just simply take an aggressive approach to prophylaxis, what's the added benefit of screening people? I agree with that. And we now have multiple high-quality clinical practice guidelines that deal with the trauma population, and there is a fairly substantial homogeneity with the recommendations of these guidelines. I won't go through them in detail next. And so I'm just, in the last few minutes, I'm just going to talk about, I'm going to make some concluding statements, and I'll give you what our approach is to try and prevent this complication. Next. So the original concept about the patients having high risk of bleeding that persisted for a long time, I think this is the #1 fundamental idea change that has resulted in appropriate use of prophylaxis in these patients. And that is that because of the amazing care that you guys give trauma patients, their bleeding risk falls very precipitously because you fix the problem that causes the patient to try and bleed to death. And the risk of thrombosis, while occasionally it happens early, is often delayed, and it leaves a window of opportunity for us to start anticoagulant prophylaxis between the decline in bleeding risk and the increased thrombosis risk. And this may seem like an overly simplistic slide, but this is, I think, the number one factor that's resulted in better use of prophylaxis in trauma, at least in my experience. Now we're in 2022. We now don't use low-dose heparin very often. We don't use it at all. And there's basically a single drug that's used, enoxaparin, and now the concept of using adjusted doses based on weight or risk or anti-10A level or TEG or whatever it is that's used, such that patients at varying risks may get different doses. VTE prevention is routine, and in most hospitals it's systematic. There's a decline in interest in using screening Doppler ultrasounds. Prophylactic IVC filters are largely gone, and now there are multiple guidelines that support the use of prophylaxis. This has all resulted in a decrease in clinically important VTE. Most of you are too young to have observed that change, but I have seen a dramatic reduction in clinically important DVT and PE and fatal PE over the time that I've been involved in trauma. Why? Some of it probably has to do with prophylaxis. I think a lot of it has to do with dramatic improvements in trauma care that you are all responsible for. So congratulations for contributing to that. Over the years at our hospital, we've come up with some priorities to decide how do we prophylax trauma patients. The number one priority is don't cause bleeding. If you cause bleeding, you're out of the game. Second priority is to prevent major VTE, clinically important VTE. We try and prevent fatal PE, symptomatic extensive PE, and extensive DVT, and that has been accomplished. And we do this consistently, and we do it efficiently, and we don't spend too much money doing it. And we also try not to make the surgeons or ICU docs nervous. In fact, that has been a very gratifying observation in our place, that in fact we sometimes have to stop prophylaxis in a patient who we are not comfortable that they have stopped bleeding. That has changed the culture. Our objectives in this area do not include trying to prevent every small DVT or trying to prevent every small PE, because we believe that small DVTs and small PEs are just part of acute illness and part of trauma care, and we don't care about them at all. We want to prevent the clinically important ones next. So I won't go through this in detail, but we have several buckets of our prophylaxis dosing. The vast majority of trauma patients at our center get 40 milligrams once a day or 40 milligrams twice a day of enoxaparin, and that dosing depends a bit on their weight and depends on whether they're average risk or high risk, which we define as spinal cord injury or lower extremity fracture. We don't use heparin at all in our trauma unit or anywhere for that matter. Since 2006, we've had a formal avoid heparin policy at Sunnybrook. We never do anti-10A level monitoring in these patients. We never do Doppler ultrasound screenings or put prophylactic IVC filters. We continue prophylaxis until the patient is discharged from acute care and from rehab. But we never send trauma patients home from the hospital after discharge on anticoagulant, after rehab or after acute care. And we have, in the last 10 years or so, we use rivaroxaban for trauma patients routinely who are beyond their acute phase, who are going to be with us or in rehab for some time, and who are at high risk for thrombosis. This is our standard. And I'll just depict that in the next two slides. So our average trauma patient, we would consider like a general surgery type trauma patients. They start on Lovenox as early as possible, and they stay on it until they're discharged from hospital. Next. In the higher risk patients, again, spinal cord injury, major lower extremity fractures, they start on enoxaparin 40 milligrams once a day, and then in a day or two, the doses increase as the risk of bleeding has gone down and their thrombosis risk goes up. And some of these patients, many of them, we switch to rivaroxaban until they're home from rehab. Next. So this is the final slide, and I just want to summarize the incredible accomplishments that you have contributed to over the past 35 years. And these are the things that I think I've learned. We can all agree that major trauma patients are definitely at increased risk for VTE if we're not active at preventing it. There's no doubt about that, I don't think. Second point is we cannot prevent every symptomatic DVT or PE, but we can sure prevent almost all major DVTs and PEs. We have not had a fatal pulmonary embolism in our trauma unit in many, many years. I think we've had 1 in 10 years. Bleeding concerns, which I've mentioned already, have been overemphasized in the past. And it turns out, as hopefully you will agree, that clinically important bleeding is very uncommon with sensible prophylaxis. We now know that uniform fixed dosing of low molecular weight heparin is insufficient for many patients. That early start of low molecular weight heparin for most patients is safe and effective. If we're using once a day low molecular weight heparin, we dose people at night, at bedtime, because there is no procedure that the patient will undergo tomorrow that requires us holding a dose tonight. So that has resulted in a dramatic reduction in missed doses. We believe in part in WIC-based dosing. We stop prophylaxis at discharge from rehab. That we don't believe that routine screening is effective and may be harmful, and prophylactic IVC filters are not needed. So I'm just going to stop there and thank you all for your huge contributions to this field, and thank you for allowing me to be here with you this week. Thanks.
Thank you. So just a quick question. We'll open up to the audience, but I just want to ask a question. You mentioned that you're not trying to prevent all DVTs, that the small ones you don't care as much about. And so my question with that is twofold. Number one is, how do you get your hospital quality officers to not care about those small DVTs? And because, as we know, it affects hospital quality rankings and things like that. And my second question is, do you treat those small DVTs? I mean, do you put them on therapeutic anticoagulation after they leave?
So there's a lot of good literature, both in trauma and non-trauma patients, that a substantial proportion of sick patients develop asymptomatic DVT and leave the hospital with asymptomatic DVT. 20% of arthroplasty patients go home from the hospital with an asymptomatic DVT. Schultz showed in the trauma population, 24% of consecutive trauma patients had asymptomatic PE at 36 hours after injury. So number one, we don't look for small DVTs, and we try not to look for small PEs because they may make us do something that's harmful to the patient. We do try and look for the major ones, and we treat those aggressively. We have never been questioned by anyone on the quality improvement side with respect to what we do, other than we are congratulated for the work that we do in this area. I'm a quality improvement person now as well, and I think that our objective should not be to find every client. And it applies to ICU patients too. If you do the same thing, if you were to do a very sensitive test in ICU patients, you would find that quarter at least of the patients sitting in our ICUs today have asymptomatic DVT, and we don't care about it because most of them are going to be fine.
I'll ask a question as well. So we have, I think, variable access to rehab in the U.S. And so you mentioned that patients that are high risk, you continue their rivaroxaban through rehab. Are there patients who are high risk that if they were not going to rehab, that you would still consider saving anticoagulation in at home?
That's a great question. And we get to send anyone that we want to go to rehab. So we get to use rehab, and so we're presuming that they're at higher risk for thrombosis because they're going to rehab, and the rehab center can give them prophylaxis. If we were faced with the situation that you mentioned, where we have to send high-risk patients home from the hospital, that would require a rethink about that, and I think I would strongly consider studying post-discharge prophylaxis in those patients. And not a simple matter, obviously, as you well know. We can justify sending high-risk patients home on prophylaxis, as we do with hip fracture patients or arthroplasty patients. We send them home on prophylaxis. We could justify the same thing in trauma patients. We just don't have good quality data. And there are all kinds of issues about who pays for the drug and compliance and all of that, which we don't know. But that would be an area that, particularly in the U.S. where you don't have as frequent access to rehab, that was very worth studying. I agree, that's a problem.
Yeah, thank you for that presentation. How do you manage patients with renal failure? Renal failure generally go to heparin.
Yeah, no, so if somebody has creatinine clearance of less than 30, the patients get 30 milligrams of enoxaparin at bedtime once a day. If they're on dialysis, they get 40 milligrams of Lovenox after dialysis. Don't use heparin in those patients. Only one patient group in our hospital who gets heparin as prophylaxis, and that is patients on continuous dialysis. So CRRT or peritoneal dialysis, and we're not worried about bleeding or accumulation in those patients. We're worried that the dialysis clears the low molecular weight heparin, so they're not having any effect. So those are the only patients we give sub-Q heparin to.
Joseph?
Thanks for your talk. Right back here, sorry. I guess I wanted to ask a little more to Dr. Bolger's question, like how do we know we're doing justice to the patients on discharge when they're going home or they're with multiple fractures or whatever it may be? Like, where's the data or do you know of data that says we shouldn't be putting everyone on sort of prophylaxis after discharge with trauma?
That we should or we shouldn't?
We should be putting.
Oh, we shouldn't. There's no way we should be putting everybody who goes home.
I guess, where does that come from, that statement?
It comes from the absence of data in trauma that you've got a post-discharge problem. That is not the case for some of the other groups, arthroplasty, for example, where there's a rich data showing post-discharge prophylaxis reduces clinically important thrombosis. We don't have such data in trauma. And from our own experience of about 25 years, where we've never sent patients home on prophylaxis, and the event rates have been extremely low. I think it is something very much worth studying, but it needs to be studied right so that we will, at the end of the day, make the right decision for these patients. It's not a simple matter. It's much more complicated, obviously, to do post-discharge prophylaxis than in-hospital prophylaxis. So we need to study it carefully.
Other questions?
Thank you, everyone.